Hello everyone, my name is Dr. Sikandar and today we will discuss about the part 3 of Gold Guideline for COPD. So in this chapter we will discuss about the management and follow-up of a case of stable patient with COPD. Yeah, first they are telling about the asthma COPD overlap. So they are telling like we no longer refer to asthma COPD overlap. Means now there is no term like asthma COPD overlap. Instead we emphasize that asthma and COPD are different disorders, although they may share common treatable traits and clinical features, but we have to treat them separately. If a concurrent diagnosis of asthma suspected, pharmacotherapy should primarily follow asthma guidelines. So if both are present, then we have to follow asthma guidelines and we have to treat first asthma and then we have to treat COPD after treating asthma. So now they are talking about like what is the protocol to follow in a patient with COPD. So they are telling like first we have to diagnose a case of asthma with symptoms, risk factor, and spirometry. Yeah. After that, we have to do initial assessment. In initial assessment, we have to check FEV1. According to that, we will classify that like gold 1 to 4. Then we have to assess symptoms. According to that, we have to check the CAT score and MMRC score. And then we have to check exacerbation history. According to exacerbation history and like CAT and MMRC grading, we have to check like either it is gold A, B, or E. Then we have to check smoking status and alpha 1 antitrypsin level and comorbidities. After that, we should start initial management like smoking cessation, vaccination, active lifestyle and exercise, initial pharmacotherapy, self-management education like risk factor management, inhaler technique, breathlessness, written action plan should be there and manage comorbidities. So after that, we have to review the patient. And if we are reviewing the patient, then we have to check the symptoms, exacerbation, smoking status, exposure to other risk factors, inhaler technique, and adherence. We have to check adherence also. Physical activity and exercise, need for pulmonary rehabilitation, self-management skill like breathlessness and written action plan. And then we have to check need for oxygen or NIV or lung volume reduction surgery or palliative approach is required or not. Then we have to check vaccination, management of comorbidities, and spirometry. So they are telling like spirometry is recommended at least annually, like once a year we have to do spirometry. After that, we have to adjust the pharmacotherapy and non-pharmacological therapy and repeat and review the patient again. Then they are telling like what is the goal of treatment of stable COPD patient. So we should relieve the symptom, improve the exercise tolerance, and improve health status. So if these things are okay, then symptoms will reduce. And for like prevent disease progression, treat prevent and treat exacerbation, reduce mortality. By these things we can reduce the risk, future risk. Now they are telling like identify and reduce exposure to risk factor. So we have to reduce the risk factor also. So they are telling identification and reduction of exposure to risk factors is important not only for the prevention of COPD but also as a part of management of COPD patient. So they are telling cigarette smoking is the most commonly encountered and easily identifiable risk factor for COPD, and smoking cessation should be continually encouraged for all individuals who smokes, and reduction of total personal exposure to occupational dust, fumes, gases, and to household and outdoor air pollution should be addressed. So they are telling identify and reduce risk factor exposure like smoking cessation intervention should be actively pursued in all patients with COPD. We have already discussed efficient ventilation should be there, non-polluting cooking stoves, and similar intervention should be recommended. Clinicians should advise patient to avoid continuous exposure to potential irritant if they are there. Then they are telling like managing inhaled therapy. So how to manage inhalational therapy. So they are telling most of the drug which we use in COPD patients are inhalers only. So appropriate use of inhaler device is crucial to optimize the benefit risk ratio of inhaled therapy. So what are the key point of inhalation of drugs? So they are telling when treatment is given by the inhalational route, the importance of education and training in inhaler device technique cannot be overemphasized. So like it is very important to like educate and train the patient like how to take inhaler. The choice of inhaler device has to be individually tailored and will depend according to accessibility, cost, prescriber, and the most importantly patient's ability and preference. Either patient want and patient can use it or not. So like choice of inhaler we have to like address. Then they are telling like if essential to provide instruction and to it is essential to provide instruction, demonstrate the proper inhalational technique when prescribing a device to ensure the inhaler technique is adequate or not, and recheck at each visit that patient continue to use their inhaler correctly. Then they are telling inhaler technique and adherence to therapy should be assessed before concluding that the current therapy is insufficient. Now they are talking about basic principle for appropriate inhalational device choice. So they are telling like we have to check either availability of drug in the device. So this drug is available or not to the patient. Then they are telling like patient's belief satisfaction is very important in this case. The number of different device types should be minimized for each patient. So we have to like finally choose only one device type. Then they are telling like device type should not be switched in the absence of clinical justification. So there should be like proper clinical justification if we are changing the inhaler. Then they are telling like shared decision making is most appropriate strategy for inhalational device choice. So like it should be a common decision between the patient and the doctor. Then they are telling patient's cognition, dexterity and strength must be taken into the account. So they are telling like patient's ability to perform the correct specific inhalational maneuver for the device must be assessed. So there are like two kind of devices mainly. First is dry powder inhaler DPI are appropriate only if patient can make forceful and deep inhalation. So if patient can take deep and forceful inhalation, only then DPI are recommended. Then they are telling like check visually that patient can inhale forcefully through the device. If there is doubt, assess objectively or choose alternative device. Then another device is metered dose inhaler MDI. To a lesser extent, soft mist inhaler require so they are telling like MDI requires coordination between device triggering and inhalation, and patient need to be able to perform slow and deep inhalation. So they are telling like check visually that patient can inhale slowly and deeply from the device. If there is doubt, consider adding a spacer. So they are telling like if patient is not able to properly like inhale deeply with MDI, then we have to like add spacer of or BSC or choose alternate device. For patient unable to use MDI with or without spacer or VSC, SMI or DPI a nebulizer should be considered. So in this case, like if patient is not good with MDI, then we can like use SMI or DPI. So they are telling like other factor to consider include size and portability and cost are also very important factor to give inhaler. Then they are telling smart inhaler may be useful to if like there is an issue with adherence or persistence, like patient use it or not, like because smart inhaler counts the number of like how many times patient has taken the inhaler device. So they are telling like this is also a good thing if there is problem in adherence. Then they are telling like key point of the use of bronchodilator. So like we used to prescribe these bronchodilators. So like what are the key points during prescribing these bronchodilators? So they are telling LAVA and LAMA are preferred over short-acting agents except for the patient with only occasional dyspnea. If patient is having only occasional dyspnea, in those cases like SAVA can be given, but in rest all the cases LAVA and LAMA combinations are preferred. Then they are telling like when initiating treatment with long-acting bronchodilators, the preferred choice is combination of long-acting muscarinic antagonist and long-acting beta-2 agonist. In patient with persistent dyspnea on a single long-acting bronchodilator, we have to escalate it to the two. The combination can be given in a single inhaler or multiple inhaler, but we have to give the combination. If patient is not uh, like improving in on single long-acting bronchodilator. Then they are telling like inhalational bronchodilator better than oral bronchodilators, obviously. Then they are telling very important thing that is like theophylline is not recommended unless other long-term treatment bronchodilators are unavailable or unaffordable. So they are telling like we should not give theophylline in patients with COPD. We should recommend only these LAMA plus LAVA combinations. Theophylline can be prescribed only if long-acting bronchodilators are unavailable or unaffordable. Then they are telling like key point for use of anti-inflammatory agent. So they are telling long-acting monotherapy with ICS, like only ICS are not recommended. We do not encourage they are telling like LAVA plus ICS combination are also not given until unless there is any indication of use of them. Then they are telling like if patient with COPD have feature of asthma, then treatment should always contain ICS. So very important thing is this like if COPD patient is having concurrent asthma, then ICS should be given. It is like must. ICS should be given. It is like must. In patient with severe to very severe airflow limitation means like FEV1 is less than post bronchodilator FEV1 is less than 50, and like patient is having chronic bronchitis and exacerbation, then addition of phosphodiesterase 4 inhibitor like roflumilast with long-acting bronchodilator with or without ICS should be considered. So like we have discussed it a lot of times. So they are telling like in severe to very severe airflow limitations, chronic bronchitis and exacerbation is there, then we should add phosphodiesterase inhibitors with long-acting bronchodilators. Then they are telling like preferentially, but not only a former smoker. So they are telling like patient is not currently smoking, very very important. Patient is not currently smoking. Then macrolide like azithromycin should be given, like it is having a good role. Statin therapy has no role, and like antioxidant mucolytic like they are given in selected patients. Then key point of like about other pharmacological treatment, like they are telling if patient is having severe hereditary alpha-1 antitrypsin deficiency and established as emphysema is there, then alpha-1 antitrypsin augmentation therapy is recommended. Then they are telling like antitussives do not, we do not recommend antitussive drugs. Then they are telling like if patient drugs are approved for primary pulmonary hypertension should not be given if pulmonary hypertension is because of COPD. So they are telling if pulmonary hypertension is because of COPD, then we should not give those drugs which we have to give for primary pulmonary hypertension. Then they are telling like low dose, long acting oral or parenteral opioids. So low dose, long acting oral or parenteral opioids can be given in COPD patients with severe disease, like tramadol kind of drug can be given in severe patients with COPD. So now again they are talking. So yeah, according to like gold category, gold group A, B, E, we will discuss what is the treatment. So they are telling like we already know like what is group A. Group A is like MMRC grade 0 to 1 CAT score less than 10 and like 0 or 1 moderate exacerbation, and there is no history of hospital admission. So this is like group A. And like what is group B? Group B is MMRC grading like 2 or more than 2, CAT scoring 10 or more than 10, and 0 to 1 moderate exacerbation, and there is no history of hospital admission. So this is group B. What is group E? Group E is like more than 2 moderate exacerbation and like more than 1 or more than 1 uh, leading to hospitalization, and like any MMRC grade or any CAT scoring. So this is known as group E. So they are telling like in group A we used to give a single bronchodilator therapy. In group B we used to give LABA and LAMA both. And in group E LABA and LAMA is given. So they are telling we should give ICS if blood eosinophil count is more than 300. Yeah, in group E patients. What is the management cycle? So we have already discussed a lot of time, like we have to review, then assess, then adjust. So like how to review according to symptoms like dyspnea and according to exacerbations. So then we have to assess like assess the inhaler technique and adherence and non-pharmacological approaches. Then according to these we have to adjust the treatment, like we can escalate the dose and we can de-escalate, and we can switch inhaler device or molecules. After that comes like follow up of pharmacological treatment. So how to follow up? So they are telling if response to initial treatment is appropriate, then we have to maintain it. Nothing to do. If they are telling like response to initial treatment is not there, then we have to check the adherence, inhaler technique, possible interfering comorbidities are there or not. Then they are telling consider the predominant treatable traits, like either it is dyspnea or it is due to exacerbation. They are telling if both exacerbation and dyspnea are there, then we have to consider exacerbation first. Then they are telling like so according to that we have two guidelines. So they are two lines of treatment. Then they are telling if dyspnea is predominant symptom, then they are telling we have to give LABA and LAMA. Then after that they are telling give LABA and LAMA, consider switch inhaler device. We have to like switch inhaler devices or molecules, like we have to switch from MDI to DPI or DPI to MDI, or like we can change the drugs. Then they are telling like drugs like in LAMA only we can interchange like different drugs. Then they are telling implement or escalate non-pharmacological treatment, obviously, and investigate other causes of dyspnea are not there. So we have to investigate that also. Then they are talking if exertion is the prominent symptom, then they are telling like we are giving LABA and LAMA. Then we have to like give ICS also. We should add ICS also if there is like blood eosinophilic count more than 300. And they are telling like then we have to de-escalate if so they are telling like how to de-escalate. So this for this graph like they are telling here, consider de-escalation of ICS if pneumonia or other considerable side effect is there. So yeah, if pneumonia or other considerable side effect of inhaled corticosteroid are there, then we have to shift from LAMA, LABA and ICS to LABA and LAMA. And they are telling uh, even after LABA, LAMA and ICS, like patient is not improving, then we can add roflumilast or azithromycin. So when to add roflumilast, we know like patient is having severe or very severe like grading of COPD, like FEV1 is less than 50% and chronic bronchitis is there and history of exacerbation is there. And they are telling like uh, we can add azithromycin if patient is like former smoker, like currently he do not smoke. Then they are telling like about individually they are talking about the group. So rescue short-acting bronchodilators. So short-acting bronchodilators we used to give like to immediate relief of the symptoms in all the patients. So in group A, already we have discussed like all group A patients should be offered bronchodilator treatment. This can be either a short-acting or long-acting bronchodilator. If unavailable, affordable, a long-acting bronchodilator is preferred choice, except in patient with very occasional breathlessness. If very occasionally breathlessness is there, then we can give SABA. Otherwise, in every case, if it is available, then we have to give LABA. Then they are telling like this should be continued if benefit is documented. So we have to continue LABA only in group A. In group B, they are telling like treatment should be initiated with LABA and LAMA combinations. And they are telling like if patient is having less than one moderate exacerbation in a year and CAT scoring is more than 10, then LABA and LAMA combination is better than LAMA alone. So LABA and LAMA combinations are given. Therefore, providing there are no issues regarding availability, cost, side effect, LABA and LAMA is recommended initial pharmacological choice of the treatment in case of group B category. So they are telling if LABA and LAMA combination is not considered appropriate, there is no evidence to recommended one class of long-acting bronchodilator over other for initial relief of the symptom in this group of the patient. In the individual patient, the choice could depend on the patient's perception of the symptom relief. Then they are talking about the group E. Uh, so they are telling like LABA and LAMA combinations were the highest ranked treatment group to reduce the COPD exacerbation. Therefore, provided there are no issue regarding availability, cost, and side effect, LABA and LAMA is the preferred choice. Obviously, they are telling LABA and LAMA is preferred choice for initial therapy of group E patients. Very very important. So in group E and group B, in both of them, LABA and LAMA combinations are like initial choice of therapy. Then they are telling use of lava plus ICS in COPD is not encouraged. Usually we do not give inhaled corticosteroids in COPD patients. If there is indication of ICS, then only we used to give LABA plus LAMA plus ICS rather than LABA plus ICS. So we should give triple combination rather than these two combinations. Then they are talking about like in group E patients, we used to give LABA and LAMA plus ICS if eosinophilic count is more than 300 cells per microliter. We have already discussed it a lot of times. And they are like finally they are telling we think there is a rationale for reserving this treatment for patient with high eosinophilic count like more than 300 cells per microliter. Now very very important statement is there. If patient with COPD have concomitant asthma, they should be treated like patients with asthma. And under these circumstances, use of inhaled corticosteroids is mandatory. So we have to give ICS, and if both are there, then we should treat first asthma. We should treat asthma. Now again, they are telling follow up the pharmacological treatment should be guided by the principle of first review, assess, then adjust if needed. So they are telling how to review. We should review the symptoms like dyspnea and exacerbation risk by the previous history and blood. We should check like previous history and blood eosinophilic counts also. Then we have to assess. So assess the inhaler technique, the adherence, and the role of non-pharmacological approaches. Then they are telling like then adjust the pharmacological treatment. Like either we can escalate or de-escalate and switch inhaler devices and molecules within the same class, like using a different long-acting bronchodilator. I have already told you may be considered as appropriate. Any change in treatment require a subsequent review in the clinical response and including side effect. So again, this whole scenario will repeat itself. Now they are talking about the dyspnea. They are telling for patient with persistent breathlessness or exercise limitation on bronchodilator monotherapy, the use of long-acting bronchodilators is recommended. Obviously, if addition of second long-acting bronchodilator does not improve the symptom, we suggest considering switching the inhaler device or molecule. They are telling like first we have to like shift from monotherapy to combination. Only after that we should switch the inhaler device or molecules. Very, very important statement. Then they are telling it at all stages, dyspnea due to other causes should be investigated and treated appropriately. And they are telling inhaler technique and adherence should be considered as cause of inadequate treatment response. Now they are talking about exacerbations. For patients with persistent exacerbations on bronchodilator monotherapy, first we have to escalate it to LABA and LAMA combinations. If blood eosinophilic count already is like more than 300, then we have to give LABA, LAMA plus ICS triple combinations. Then they are telling like in patients with who develop further exacerbation on LAMA plus LABA, then like they are telling if blood eosinophilic count is less than like 100, then we should not give ICS. If it is like more than 100 or more than 300, then we should use inhaled corticosteroid. They are telling like if patient treated with LABA, LAMA and ICS triple combination still have exacerbation, then we should like add roflumilast if like FEV1 is less than 50% predicted or patient is having like chronic bronchitis and like have experienced as at least one hospitalization for exacerbation in previous year. And like they are telling again, they are telling about macrolide. They are telling like best available evidence exists for the use of azithromycin, especially in those who are not currently smokers. And they are telling consideration to the development of resistant organisms should be factored into decision making. Obviously, like it can lead to development of resistant. Then they are telling like about the withdrawal of ICS. They are telling withdrawing ICS can be considered if pneumonia is there or considerable side effect of ICS are there. If blood eosinophilic count more than 300 cells per microliter, then de-escalation is more likely to be associated with development of the exacerbation. Carefully consider the dose of ICS used to reduce potential of ICS related side effects that are more frequent at higher doses. Now they are telling about the patients under treatment with LABA and ICS. If patient with COPD, no feature of asthma has been treated for whatever reason with LABA and ICS and are well controlled in terms of symptoms and exacerbation, then we have to continue LABA plus ICS. So this is our option. Yet if patient has further exacerbation, then they are telling we should shift the patient from LABA plus LAMA plus ICS. And they are telling like major symptom uh, is there, then we should switch to lava plus lama should be considered. So they are telling like if exacerbations are there, then we should add ICS, or if dyspnea is there, then we should like remove the ICS and we should continue patient on lava plus lama. Now they are talking about the non-pharmacological management of COPD. So they are telling like in group A, we should like focus essentially on smoking cessation and physical activity is recommended. And they are telling depending upon the local guidelines, we should give like these 5 vaccines. First is influenza vaccine, second pneumococcal vaccine is there like 15, 20 valent and 23 valent. Then pertussis vaccine, which is known as DTaP vaccine, is given if it has not been given during adolescence life. COVID-19 vaccination is recommended, and like singles vaccination is given in patients if age is more than 50 years. Same vaccines are given in B and E group, and like physical activity is recommended also here. Like, but like in B and E group, uh, after like smoking cessation, they are telling pulmonary rehabilitation is also essential. So like in B and E group, pulmonary rehabilitation is essential, and like in group A, it is not essential. They are telling about the follow-up of the non-pharmacological treatment. They are telling if response to initial treatment is appropriate, then we have to maintain it. And they are telling we should offer the flu vaccine like influenza vaccination every year and other vaccination according to guideline. They are telling self-management education are given, and we should like assess the like smoking cessation and other environmental exposure and ensure the exercise program, physical activity, adequate sleep, and healthy diet. So these things are also required. Then they are telling like If not, like response is not there, then like we have to like check the predominant treatable trait. So either it is dyspnea or it is exacerbation. So they are telling like if it is dyspnea, then like in both of condition we should like give self management education, and there should be a written action plan should be there. After that, they are telling if it, dyspnea is predominant, then they are telling like breathlessness, energy conservation techniques, and stress management strategies are provided, and pulmonary rehabilitation is provided. And they are telling if exacerbation is like predominant, then they are telling avoidance of aggravating factors is provided, and how to monitor, manage worsening of symptoms, and contact information in event of the exacerbation we have to give. After that, they are telling like all the patient with advanced COPD should be considered for end of life and palliative care support to optimize symptom control and allow patient and their family to make informed choice about the future management. After that, talking about the prescription of supplemental oxygen to COPD patients. So they are telling like if arterial hypoxemia is there, like what is arterial hypoxemia? So PaO2 level less than 55 mmHg or 7.3 kilopascal, or saturation of oxygen is less than 88%, like PaO2 less than 55 mmHg and SaO2 saturation of oxygen is less than 88%, or they are telling if PaO2 is between 50 to 55 to 60, like it is more than 55 but less than 60, with right heart failure and erythrocytosis is there. So they are telling like there are signs of chronic hypoxemia are there, like right heart failure and erythrocytosis is there. Then they are telling like we should prescribe supplemental oxygen, and then we have to titrate and keep it uh, like till 90% or more than 90%. So it should be maintained at 90%. Then we have to recheck in 60 to 90 days to assess if supplemental oxygen is still indicated or not, or if prescribed supplemental oxygen is effective or not. Then they are talking about the ventilatory support. They are telling like NIV is occasionally used in patients with stable COPD patients. They are telling in selected group of the patient, particularly in those which are having pronounced daytime hypercapnia is there and recent history of hospitalization is there. In those patients, they are telling like we have to give NIV. In contrast, in patient with both COPD and OSA, there are clear indication of the use of CPAP. If patient is having like OSA and COPD, then we should give CPAP, continuous positive airway pressure. After that, they are talking about the key point for the use of non-pharmacological treatment. Like already we have discussed these all things, so I will proceed on the next. I want to discuss like few things which have been not discussed. Like they are telling in education management and like pulmonary rehabilitation, they are telling like education used to change the behavior of the patient. And here they are telling like physical activity is a strong predictor of the mortality. People with COPD should be encouraged to increase the level of physical activity, although we still don't know how to best ensure the likelihood of the success. But yeah, it is a strong predictor of mortality. So we should like promote physical activity in patients with COPD. These things we have already discussed. So I will move further. They are talking about the end of life and palliative care. All clinicians managing patients with COPD should be aware of effectiveness of palliative approach to symptom control and use in their practice. End of life care should include discussion with patients and their families about their views on resuscitation, advanced directives, and place of death preference. So we should discuss these things with patient and their families. They are talking about treatment of hypoxemia in patients with severe resting hypoxemia and long-term oxygen therapy is indicated. Already we know these things. They are telling treatment of hypercapnia. So for those patients, we used to give long-term non-invasive ventilation. So yeah, this is like important thing. So we will discuss this thing like intervention, bronchoscopy, and surgery. So yeah, they are telling like lung volume reduction surgery should be considered in selected patient with upper lobe emphysema. So like if there is upper lobe emphysema is there, then we can do lung volume reduction surgery. In selected patient with large bulla, surgical bullectomy may be considered. So we can do large bulla surgical bullectomy in selected patient. They are telling in selected patient with advanced emphysema, bronchoscopic intervention reduces and expiratory lung volume and improve exercise tolerance, quality of life, lung function at 6 to 12 months following the treatment. So what are those like bronchoscopic intervention? Those are like endobronchial valves, lung recoil, and vapor ablation. endobronchial valve, lung recoil, and vapor ablation is we used to do these interventions. After that, they are talking like in patient with very severe COPD and like body score of 7 to 10 and not candidate for lung volume reduction. Like in those we can't do lung volume reduction surgery. Lung transplantation may be considered for referral at least one of the following with at least, so they are telling these like uh, three things are there, so out of these one thing should be there. So they are telling history of hospitalization for exacerbation associated with acute hypercapnia, means like PCO2 level more than 50 is there, so history of this thing is there. Or they are telling pulmonary hypertension core pulmonary despite oxygen therapy has been given, but after that pulmonary hypertension core pulmonary is there. And third thing is like FEV1 is very less, like less than 20%, and like DLCO is less than 20% or homogeneous distribution of emphysema is there, then lung out of these three things, one is there, then we should consider patient for lung transplantation. So that's it for like third part. I will discuss fourth part later. So that's it, guys, for today.